This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week on the program, my guest is Anthony Santarelli, Ph.D. He is the Director of Research and Sponsored Programs here at KRMC. Dr. Santarelli, welcome back.
Hello, TG. How are you doing today? Always a pleasure.
Thank you. Great. I'm glad to see you. It is always a pleasure. Today on the program, the Neurobiology of Addiction. When I saw the title, I said, I need to know more about the neurobiology of addiction. This is perfect radio material. So tell me about this study and where it comes from.
Well, so the study you're referring to, really interesting one, is actually an activity that KRMC is engaging in to promote active surveillance of drug use and misuse within kind of the greater Mojave County region. So this study in and of itself was really focused on trying to identify a source or come up with some predictive measures of just how much use is out there and what those side effects of use might be, both on an interpersonal level for individuals and how it may impact how people are cared for when they present to a hospital or hospital system with substance use disorder. So when we engage in kind of these surveillance studies, it's important to note that there's always a clamoring for coming up with active predictions of how much both licit and illicit, and that's to say legal and illegal drug use, exist within a general area or within a general population. So you can always index things like justice reports, vital statistics, so things with maybe deaths that are associated with overdoses, or what we've done in here is look at urine drug screens for individuals seeking medical care, both either for a medical or mental health issue when presenting into the hospital. And you see how all of this data kind of merges together to say we have individuals suffering from substance use or engaging in substance use, and they may either be identified through the justice system, or they may be identified through some adverse effect on their health and wellness. So this is one small component in Mojave County's greater response to identifying the actual need for services to treat and help people who are suffering from adverse effects of drug use.
Is this a project that you guys you and your team, you put your heads together and you say, this is something we need to look at? Or do people maybe in the community or with the hospital say to you, hey, we're seeing these cases rise. Can you study this and try to break it down for us? What's the origin of it?
So this study was actually really fantastic. It was originally brought to us by one of our psychiatric nurse practitioners who had started in the hospital here. And she wanted to get a good representation of who are potential individuals suffering from substance use disorders, how prevalent is it within the community, and then what kind of interventions are currently available to them and show benefit for them whenever they end up interfacing with a hospital system. So we use studies like this to organize our hospital's response.
Let's talk a little bit about some definitions. I want to ask you about substance use or substance abuse or drug use or drug abuse, or are we talking about the same things? I know that there are some semantics involved, and I don't know, so help me out.
So generally, we try to steer people away from talking about substance abuse, and we move into a lens of substance use disorder. Most people are engaging with exogenous substances or something that we take into our body to change our function over the course of the day in one regard or another. You think about it as caffeine, you can think about that as nicotine, you think about that as alcohol, THC, these legal substances that we're now starting to see.
Does food qualify in this, or is that outside the purview of what we're talking about?
So that's a fantastic question. From a strictly neurobiological standpoint, while there are differences for how, say, unique drug classes interact with our brain systems to promote recurrence of a behavior or
Sure.
use of a behavior, the core function of reward within our neural processing is the same for drugs, is the same for food, is the same for sex, is the same for gambling, is the same for shopping, is the same for anything that we engage with in the outside world, and then form a representation within our brains and cause us to take a pause back and say, ooh, that was good.
That felt pretty good.
I want to do that again.
Okay.
So whether it be, opiates, whether it be marijuana, whether it be cocaine, whether it be winning big in Vegas, oh, that felt good.
Yeah.
I want to do it again.
Yeah.
And that's all building on a scaffold within your brain that was originally developed from an evolutionary lens through food-seeking behavior.
It's fascinating. Yeah. Okay, I know that we're going to come back to this later on, but you say, well, we try to avoid substance abuse. And is the idea there that there's some judgment involved in that term?
So one of the major concerns, particularly when you're dealing with a clinical population, is that of stigma. As healthcare providers, one of the issues that we can see is actually running patients away by putting outside stigma onto them and making them feel at fault for coming and receiving care. So we try to avoid substance abuse, and we just say it's a substance use disorder. That parallels with how treatments can be applied, where we're not trying to cut out substance use as a whole, cold turkey, but we're trying to reduce either the amount that is being used, the locations that they're being used in, or the timeframes, environments, or peer groups that substances are used in relation to.
Yeah, language is one of my preoccupations, right? And I'm thinking about George Carlin had this bit where he was talking about soldiers returning from war. And he says, I'm not sure if I have all the facts right, but basically like World War I, they returned with shell shock. World War II, they returned with battle fatigue. And then subsequent wars, it was post-traumatic stress disorder. And his point in it was that we can dress it up in whatever language we want, but if we're not taking care of these people and their mental health needs, it's all semantics and it's all a tap dance. And so to play devil's advocate, is there a bit going on with that here, which is to say, like in 10 years, after 10 more years of saying substance abuse disorder, will that have the same awful stigma and we'll have to then search for some cleaner, friendlier term that makes us feel better about ourselves?
Well, so I think the important thing about how our language around this changes over time is how effective it is at informing actions that we take in regard to that. So George Carlin's skit on shell shock and PTSD is one of my favorite.
Oh, you know that one?
One of my favorite ones. I actually use it in my 200-level neurobiology classes for undergraduates to discuss this. So if you think about, say, when we include post-traumatic stress disorder, we're actually adding definitions to that description. So we know it's a stress disorder. We know that it's impacting stress systems. It's causing an elevation of these hormones like cortisol that give us the jitters or stress us out in a way. And we know that its antecedent, or the thing that causes it, is a traumatic experience. So we've defined shell shock, so from a bomb going out and then being put into a condition of shock, as a definition to describe the disorder as a traumatic experience has occurred, and now you have a hyper-responsive stress system to things that are associated, or stimuli that are associated with that traumatic experience. So it provides a definition not only for a clinician who may be trying to help an individual cope with, overcome, and resolve some of those issues, but to the individual suffering from those mental health concerns, to promote a greater understanding that their biology is out of function. And with that dysfunction in biology, it's not a dysfunction on themselves. I don't think that really answered your question.
No, it's very good. I mean, I think what you're getting at is that it's not merely a linguistic shell game, that it's that the changes represent an evolution in the degree and the stages of care for these people.
And the degree and the stages of understanding that we have for the root cause of how these manifest within people.
That's great. Yeah, well answered. That sidetrack grew out of giving some definitions. So let's talk. I know that coming up, we're going to talk about monosubstance and polysubstance. So can you define those for us?
Absolutely. So when you think about mono and polysubstance use, it's whether or not individuals who are coming in for care and or engaging in substance use in and amongst themselves are doing so for a single substance. You think of that as a taking an opiate or taking an amphetamine, or a polysubstance use where you start to mix these substances and the effects that they can have on your physiology change rather dramatically when in combination with one another. And it gets tremendously more difficult to resolve polysubstance systems because you're no longer trying to minimize use for a single drug. Mm-hmm. You're trying to minimize use for multiple drugs, which when you titer one down or reduce the level that an individual is taking one of them, they may rebound or self-medicate by increasing the dose of the other that they're taking in response. So it changes the lens through which clinicians are able to work with the patient and provide a whole person understanding of all the issues that person might be dealing with.
Also coming up, you're going to talk about neurotypical and neuroadaptations.
Right. So that really digs into what we call the neural circuit model of addiction. And when we think about how our brain processes addiction, and really this is when I'm going to decouple away from drugs and tell you that we can talk about food and we can talk about sex, we can talk about gambling in any real regard. So, what we think about is we think about neuroadaptations that can happen in response to a rewarding behavior. And they happen at multiple levels kind of throughout our physiology. They can happen at the individual cellular level. So that is a single cell within our brain that relays and communicates our intentions, our thoughts, our behaviors, and our actions by increasing the strength at which they connect to one another, by increasing the likelihood that they will respond to a drug or a substance. Then we can think about our neural adaptations within synaptic systems. So that's how they individually communicate with one another. And we can think about our neural adaptations between circuits as a whole. So whether or not we're going to re-engage in that and whether or not we're going to reinforce that behavior based upon how that information is perceived in the end state. If you engage in a behavior, go to Vegas, say, for a day, and you strike it big on gambling, that's really rewarding. You're going to reinforce that circuit that led to that behavior. Whereas opposed to if you go in and lose for that day, you're likely to decrease the likelihood of engaging in that behavior. So we adapt to every experience that we engage in. Drugs in particular, and rewarding behaviors in particular are major drivers of neuroadaptations. Mm-hmm. They all do so through a couple of different processes that are centered around a couple of neurotransmitters, which I think most people would be familiar with at this point. So that would be things like dopamine. Mm-hmm. That would be things like oxytocin. Okay. And that would be things like hypocretin and/or/orexin. Okay. They're the same thing.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week on the program, the Neurobiology of Addiction. My guest is Anthony Santarelli, Ph.D. He is the Director of Research and Sponsored Programs here at KRMC. So, investigating emergency department utilization and behavioral health interventions in rural Mojave County. This is the name of your study. Let's talk a little bit about the methods and what you learned.
Yeah, absolutely. So, as I may have mentioned before, so this is one of our large-scale surveillance studies to better understand, predict, and identify how many individuals within our community are suffering from substance use disorder. The methods in and of itself are ongoing. We're still collecting data associated with it. Some of my fantastic research assistants are out there collecting this data as we speak. And really what the key is identifying a single source to do that prediction. What we can use, being a healthcare institution, is people presenting in with illnesses and or injuries, which may have a root cause of substance use disorder. You get into a car crash or you get into a domestic abuse situation. Often you'll find that substance abuse is a root cause or antecedent for the injuries associated with those presentations into a hospital.
Sure.
So the study itself went through, and the one you're specifically speaking on, went through about 31,000 presentations or 31,000 points of contact in with our healthcare system.
Wow.
And through about 800 positive detections of comorbid substance use disorder. Now, the vast majority of these patients weren't diagnosed with substance use disorder, as it was secondary to the medical complication that they were there for. And the issue that we identified was, without clear definitions on that root cause or identifying patients with substance use disorder, we were closing the door to a lot of available treatments to them to help them get off of that root cause and kind of turn their life around. Kind of broad strokes overall for Mojave County, what we're finding for those with substance use disorder or for those who have a substance on board when requiring medical care.
Right.
We see a couple of really interesting things. One, it largely converges with national rates. Substance use is up. It continues to go up. It's been going up for about 2 decades. We're seeing increases in illicit opioid and illicit benzodiazepine use within the area. And then really, for broad strokes, men are the major concern. We are in Mojave County, or for the population that presents to Kingman Regional Medical Center, they're at a higher rate for both non-illicit and illicit substances or illicit substance use. But the interesting thing is women who are coming in are engaging in these substances and then having adverse medical outcomes at a much younger age than are men who come in to present. And unfortunately, when women are coming in or requiring medical interventions for their substance use, they are often being undiagnosed with that substance use disorder, and and disproportionately being underdiagnosed with their comorbid mental health issues. So it's a really underserved population within this community, are young, otherwise healthy females who are requiring points of contact for a root cause of substance use.
If this is a change over the last 2 decades, is that underdiagnosis, is it part of it is maybe a lack of training or an inability to recognize this change?
And you're absolutely right. So that's where we can talk about some of the outcomes for studies like this directly. So we've engaged in pretty consistent education for individuals working within the emergency medical services here to slow down and ask the question if there's anything that might have predisposed this individual to coming in at this time, that being substance use disorder.
A couple of things. So when we talk about data collection in a medical setting, I know people are always concerned about patient privacy.
Absolutely.
So in terms of the study that you've done, I'm sure that all this data was collected and sort of separated from patient identifiers.
Absolutely. So it's a really important first step. So we're lucky enough at Kingman Regional Medical Center to have an institutional review board, which acts as ethical oversight for all of the research activities that we engage in. And their first stop point is we need to make sure that people whose hands are touching this data can't identify an individual to the data that they're seeing.
And you've touched on this a little bit, but some of the implications, based on what you've learned from the study and the numbers that you've processed, what are the implications for the hospital, for health, and for people who are experiencing substance use disorder?
So, unfortunately, we're woefully underserved in Mojave County for substance use disorder and substance use counseling and or treatment services. So we're looking to expand those within the hospital as it is right now. What it means for patients specifically, that if you have concerns about substance use disorder, there are going to be people who are present either at a emergency department presentation or during an inpatient stay who will come and talk to you about your substance use disorder, if you would like that. And then if you would like further counseling, there are now networks available to get that delivered to you in a much shorter time and within your home community.
This surveillance that you and your colleagues have done has also highlighted a few other maybe social changes, a few other items of concern.
Yeah, so one of the major concerns that's really cropping up that has my team scratching their head on how we can serve these are in 2020, when we started the earliest points of data collection for the surveillance, we were seeing high rates of monosubstance use. So people were coming in positive for one thing, and we're seeing the rates of polysubstance use starting to drastically outstrip that. So and that includes not one, not two, but as many as 3 or 4 substances patients are often coming on board for when they have a medical complication with a root cause of substance use disorder. So the most typical patient, for example, who has substance use disorder that we're seeing in our hospital is positive for opiates, is positive for amphetamines, is positive for THC and alcohol. So that's 4 different substances that largely have divergent effects on the brain systems and behavior that an individual is going to engage in. We have uppers on board, we have downers on board, we have dissociatives on board, and then we have all of those intermixing to make a very robust and difficult clinical profile.
Right. Is marijuana legal in Mojave County?
Marijuana is legal
in
Mojave
Arizona,
County,
right?
And Arizona as well.
Okay.
Yep.
And so when we're talking about legal versus illicit drugs, we're still keeping score of alcohol and marijuana, although they are legal.
Absolutely. There's a disconnect between jurisprudence on a drug and between medical interventions that might be necessary on a drug. Mm-hmm. And if you get into a car crash, whether or not you have illegal opiates on board or whether or not you've been prescribed those opiates for, say, a chronic pain condition, it doesn't matter. For the treatment, it doesn't make so big of a difference if it's you getting it from an illegal source or a legal source, but you need help with a root cause of, say, opioid use.
Dr. Santarelli, let's talk a little bit about the neurocircuit model of addiction.
All right, so when we think about the neurocircuit model of addiction, I really think it's important to note first that we're going to drill down in. Within your head is an organ called the brain. It is the primary function for how we learn, engage with, and interact with our environment, how we grow, how we develop the thoughts that we generate, the emotions that we feel, and the sensations that we feel kind of throughout our body. And while there's a lot of granular detail to understand how addiction impacts our neuroarchitecture, there is, in general, 3 subsystems which I think are important to address. There's what we call an associative subsystem, or how we learn to do a thing, that are impacted by drugs, that are hijacked by addictive substances, that are reinforced behaviors that are rewarded. We have a limbic subsystem, which is our emotional response. So how we feel when we engage in a behavior or we seek a drug or take a drug. And then we have our motor subsystem for how we actually organize our body's response to behave and act in that way. So all of these act largely functionally from the cortex down, where we'll start kind of at the front of our brain with our executive kind of functioning control, where we choose to make a decision. So the first thing that will happen often is we'll choose to make a decision on whether or not to engage in substance use or disengage from substance use. If we have a pattern of behavior where we engage in that use, the decision to engage again is much, much easier, or it's disinhibited through those frontal regions. When that process is down, it will interact and intersect with our limbic subcircuit, and it will either make us feel really good or really bad, depending on the cumulative weight of all of the outcomes from the experiences that we had when using a drug. So if we've used a drug a lot and it feels really good each time we do, that has a positive affect or positive emotional load, once again reinforcing that system, making it easier to engage in. But if we've had negative outcomes, maybe run-ins with the law, adverse medical effects, getting into a car crash, that makes it easier to inhibit that drug use or that circuit and system to engage in. And then finally we have its interaction with the motor component. It can feel really good, and it can seem like the right thing to do, and it can feel really good to do it. But if we can't mount the response to drive down to the corner store and pick up the 6-pack for the day, then it's all for naught, and all of those are kind of out the window. So we interact on all 3 levels: learning about this, having an emotional load associated with this, and engaging in a behavior to use.
That is Anthony Santarelli, PhD. He's the Director of Research and Sponsored Programs at Kingman Regional Medical Center. Dr. Santarelli, thanks so much for your time today.
And thank you so much for coming in to shed some light on these issues.
And that is the program. Let's focus on your health. I'm TG Lafredo, and thank you for listening. We'll catch you next time.